Good morning to you all, and we move to the next IC. That's Masterclass in Central Serous Chorioretinopathy. Over the last 10 years in medical retina and macular disease, somehow I have been, I've taken some interest in this particular disease, and it's quite intriguing. And as we get more and more literature, as we see more and more patients, I think we have understood that it's not that simple a disease, but definitely a complex disease. So I would like to invite here my co-instructors, Dr. Ajay Arora, please come, Dr. Jyoti Prakash, Dr. Anubhav, Dr. Vignesh. I also have my senior colleague Mahesh, please come and join me. And you come here. Please try and find more seats and sit together. So we have a mix of faculty, quite a few of them working with us. And Mahesh, of course, is a well-known person. He is the head of the department in our institute. And before we start with Cscr, we have a keynote address by Dr. Ranjana Mathur. She is a senior consultant medical retina at the Singapore National Eye Center. And I met her many times. Dr. Ranjana, please. I will request all speakers to please keep up with the time so that we have enough time for discussion.
Thank you, Dr. Giri. We were discussing yesterday the connection between CSCR and cataract, and I'm sure at the end of my talk, you will be able to know the difference. So you would wonder why, when I'm a solo cataract surgeon, do I need to know this? And as we go through the talk, you will realize how important it is for each of us to have this clarity. Because in group practices, there may be many doctors or optoms or nurses that may be involved, but in solo, maybe not, yet the errors may occur. And all you need is one error, one medical legal case, and that would do the harm to your practice as well. So, first, do no harm. These were the documented literature cases where people came forward to share their problems with wrong IOLs. And it's only on the rise. As you go to many different conferences, you will hear more of these happening. So let's look at the key points in patient safety. What is it that causes these errors? If you look at it, if you have all these 6 points covered of detailed clinical documentation, clarity between communication, multiple checkpoints, avoiding transcription errors, doing a proper universally protocoled timeout or near misses that you look at your data for, you will avoid all these. So let's see, where do these errors occur. I looked at in my journey as risk management officer, I looked at the data of SNEC to see where are we having these near misses. And I looked at my data, I realized that there is a huge number of process errors that we were having at that time. But when we changed our manual human related practices to go to digital, we realized we could then reduce these errors from almost 80%. But the surgical errors could not. And we'll look through it why. So, for each of us in our practices, these are the steps when we look at the patient, plan biometry, then select a lens, and then we meet the patient on the surgical day. And this, again, like I said, involves a lot of team members. So, what happens in the pre planning or listing stage? Here, the errors may occur if you have not clearly indicated which eye, what is the choice of IOL that you chose, what is the post-refractive aim, whether you wanted plano, micro mini, or monovision, and the choice of IOL, which company, what multi, EDOF, or monofocal. Once you have clearly communicated this, could you then trace these communication between patients, between your consultation with them and the operative surgeon? Because the patients can change their mind, and if they do change their minds, this must be communicated somewhere, and the surgeon must know about it. Or to be on a safer side, you may want to arrange another consult so that you know what's going on. What about biometry related errors? Beautiful talks yesterday by various groups where they really in detail looked at the biometry related errors. And you may have all those errors taken care of by having a well trained technician and the rest, but yet they occur. Why? Because you did not communicate to the technician what you wanted. They may not have used the correct formula, in the sense LASIK eye, but normal formula used, and a post silicon oil, normal formula used. So we have devised this form where we very clearly communicate with our technician what we want and also the eye of the condition. So like in this case, it's normal and this is what we may want, and the technician then knows what to do. Similarly, technicians also communicate with us, telling us if there is anything amiss. Like in this case, the patient may have a very flat cornea, but the patient has had no previous LASIK surgery. Not only that, we have two checkers. So once the biometry technician has filled up her or his data, there is second checker who makes sure that the data of chemistry, excel length, everything is accurate. Then comes a surgeon. Why do then we make mistakes? We make because mainly because of inattention. We've not paid attention to what we wanted, what the patient wanted. Did we check the IOL again or the refractive aim in our case notes, or did the patient change its mind about the IOL and we did not communicate it? And lastly, transcription errors. Transcription errors occur because of our fantastic handwriting that each of us have. But there are other reasons as well. Like in this case, we only have one printout, one eye. We do not print out the calculations of both eyes on one page. And for ease of reference, we also ensure that each and every aspect of the biometry is circled. And then this is what is used as a universal paper when we are doing timeout. If you do not check this, and instead of this, if your technician has put silicon oil for measurements, you may be off by almost -2, -3, and the patient will have a refractive surprise. At the end of the surgery, we put a completed stamp so that this biometry is never looked at again when you do the other eye. This is just an example of how art or artoric kind of documentation we have completely stopped. We also do not want any transcription errors. Like there was a case where a 22 was considered as 27 and 17 was considered as 11, and we had near miss. We had a near miss in one and we had an SRE in the other. So we completely stopped transcription errors by avoiding any writing, and we had this devised form where this is a digital form where we have two identifiers. Once you go into the system, you click on the IOL, it automatically populates which eye is going to be operated. It then you have a choice of multifocal or EDOF or multifocal options. If you choose within the multifocal or any of these options what IOL you want, it gives you a choice of what lens power you have, and also gives you a reference of what is available in that particular IOL. Then you submit it, and once you submit it, if this is non-inventory IOL, say has a toric of -4, the IOL is not readily available, needs to be ordered specially. It will tell you that it requires time. You cannot give a date very early. Similarly, if you're beyond the range of the diabetic range, these are just to tell the surgeons when we have a choice of a lot of IOLs, what is available. And if you do go online and then get your IOL, you have to then go ahead and do this timeout in the clinic with all the parameters of patient identifiers, actual length, as well as a chemistry. Then the case that you have submitted for IOL gets sent to OT, and then OT will reserve the lens. So now this is done. So there should be no further room for error, right? But there can be. Why? Because there are such look-alike lenses. One is a toric, one is a multifocal. And if you do not educate your staff in the OT about these differences that exist in these power, they will make errors. And so we devised this for removing this potential confusion. We devised this intranet where each and every IOL that is used in NSE, the details are written, and we only use these model details for our timeout. We do not use either Vivity or Panoptics or any of those names for our timeout processes. And this is to standardize the process of our timeout that we do in the theater. Another word of caution, please remember the models look the same. If you do not pay attention to the plus or the minus signs, you will end up having some error. So this is my last couple of slides where this particular group shared their SREs and what may be the causes of it over the 10 years period. And as you can see, more than 50% of the cases are because of the wrong IOL implants. And when they enumerated their reasons for it, these were the reasons. One of them is that you do not have a universal protocol that you follow during the timeout, and the SREs will then occur because of those reasons. So the take-home pearls would be that it these are the ones that I just discussed, that if you can address each and every one of them, you will realize that you will not have SREs in your practice. Thank you very much.
Thank you, Ranjana. I mean, we can have 2 minutes for discussion. Any questions? Any to Dr. Ranjana? Very important talk. I mean, from the point of view of, yeah, please.
Hi, Rupal. In doing what, the timeout? No, actually, if I look back 10 years ago when I hadn't instituted some of these practices, we used to take longer because last minute we would realize, oh, this is a wrong lens in the theater, or the lenses are not arranged, or they arrange the wrong company. So once these processes become second nature to your practice, you realize they are very efficient. And timeout is one time when everybody is standstill. I, as a surgeon, not only look at my clinical notes, I look at the lens that has come into the theater and the printout, and nurse and I together will make sure that this is correct. And touch wood, there haven't been SREs since we have instituted the system. Thanks, Rupal. Thank you very much.
Thank you, Ranjana. I think
No, we don't operate on the same day as the day we list. There is always a lead time between listing and then patients have to come another day for the surgery. It's not on the same day. Not in our institute, we don't do. And there's nothing wrong in that
yeah.
also, because if you have taken due diligence in making sure that the lens that you have discussed with the patient is that lens, they may as well take it home, but then the responsibility is that they have to bring it back. So I have seen this happen when I do remember when I was a resident in India, we used to do that as well, because it was safer for the patients to take it rather than the lens getting lost in the transit. Yes, we do. Yeah. Yes, we do.
Thank you, Ranjana. I mean, thank you. I think the take-home message is each institution should develop a very strong SOP as far as IOL calculations, measurements, and also the system, because multiple people come into this. Not only the surgeon, the optometrist, then you have the nurses, then you have the OT staff. So you have multiple persons are coming into the scheme of things. So there's always a possibility of error. So we move into the IC course on CSCR, and I request Dr. Lekha to please give the first talk on current understanding of the pathogenesis of central serous chorioretinopathy. Dr. Lekha is a senior consultant in medical retina in our institute in Cochin, and she has got years of experience.
Thank you, sir, and I thank the scientific committee of AIOC for giving me this opportunity. Central serous chorioretinopathy, or CSCR as we call it, is a potentially blinding disease of the pachychoroid spectrum characterized by serous retinal detachment with or without pigment epithelial detachment and a thick choroid. The risk factors associated with CSCR ranges widely from corticosteroids, increased sympathetic drive, systemic hypertension and autonomic dysfunction, psychological stress, infection, inflammation, ocular causes like hypermetropia and a thick choroid, and genetic factors, of which the most recognized risk factor is the role of steroids, which can be explained by the mineralocorticoid pathway hypothesis. Normally, the glucocorticoid or the cortisone is converted into cortisol by the enzyme 11-beta hydroxysteroid dehydrogenase type 2. This enzyme is relatively deficient in retina and choroid, so this conversion is not happening, which means there is excess of glucocorticoid in relation to aldosterone, and they goes and illicitly occupies the mineralocorticoid receptors. Normally, glucocorticoids causes vasoconstriction, but here when they occupy the mineralocorticoid receptors, they could give the opposite effect. They cause vasodilatation, it becomes pro-edematous and pro-inflammatory, and all this is happening through the upregulation of endothelial calcium-dependent potassium channels. It also causes loss of RP adhesion and Brooks membrane remodeling, finally leading to SRF accumulation. So this means that because this MR activation is pathogenic, there could be a role for long-term MR antagonist in the management of this condition, and this has been validated in rodent models. Genetic associations are also important because several familial cases have been reported, but no clear inheritance pattern has been established. The various genes that has been associated includes complement factor H, which binds to adrenomedulin and stimulates choroidal dilatation, and another is cadherin 5, which is important in maintaining the integrity of endothelial cell adhesions, and dysfunction of this can lead to leaky intercellular junctions. But it's more likely that these genetic variations combined with the triggering events such as steroids can explain the CSR in a subset of patients. Now, if you go into the pathogenesis, we can see that the understanding of the disease as well as the terminology used to describe it has evolved over years. It started off as retinitis by von Graffe, then the role of stress was recognized from that time itself, and it was Momini who demonstrated that the leak is actually happening at the level of the retinal pigment epithelium, and Donald Gaz was the first person who proposed the role of the choroid. He suggested that as the choroidal hyperpermeability that is important in the pathogenesis, and finally with the introduction of the pachychoroid spectrum, CSCR became an important entity of this condition. So what is this pachychoroid driven process? Which means we have a thick choroid with abnormally dilated vessels known in the Haller's layer known as the pachyvessels, and this dilated layer will lead on to compression of the inner layers with attenuation, ischemia and vascular remodeling, and this progress to RP dysfunction with breakdown of the blood retinal barrier where the fluid escapes into the subretinal space. And steroids also have a role in this pathway, and this is all basically showing the inflow mechanism where the fluid is coming from a thick and hyperpermeable choroid. But what actually causes this pachychoroid and this pachyvessels? It's found that the dilatation of these vessels occurs due to a back pressure because of some abnormality in the outflow mechanism, and there is what is called as a venous congestion in the choroid due to various factors like asymmetrical veins, intervortex vein anastomosis, and arteriovenous anastomosis, and this is exacerbated by a thick sclera which is often found in these eyes. And this sort of continues as a cascade with continuous chronic venous congestion leading to choriocapillaris changes, again leading to anastomosis formation, and this is now what is known as a venous overload choroidopathy, which I am going to explain in my next few slides. So this is a normal picture of a ultra wide field SEG angiography and the Serous OCT image, and it is because of the availability of these newer modalities that we have been able to understand the venous drainage in the choroid and the vortex veins. Now, compared to the normal picture, we can see here that the inferior vortex veins are much more dilated compared to the supranasal vein. So there is an asymmetry which you can see in this Serous image also, and it is found that while asymmetry can be seen in normal subjects, it is seen in almost 100% of eyes with CSCR, and in such situation in asymmetric veins, when the dominant vein is congested, then it can lead to increased permeability of choriocapillaris in the macular region. Apart from these asymmetrical veins, there can also be intervortex vein anastomosis. Normally, the vortex veins do not cross a watershed zone. Here we can see these veins cross and they form anastomosis. And in the Serous OCT image, we can see this anastomosis is much more common in CSCR compared to a fellow eye and a normal eye. So these kind of anastomosis can increase the venous congestion. It can also be a consequence of the venous congestion, and maybe resolution of these anastomosis could be taken as an endpoint biomarker to monitor the therapeutic response. And if you see the spectrum, we can see as the anastomosis increases, the choroidal congestion is alleviated, leading to a decrease in the thickness of the choroid. Now, choroidal circulation is generally, the arterial system is considered as an end arterial system, but it is possible that small anastomotic connections can form between the arterial branches of the short posterior ciliary artery. It is also possible that arteriovenous anastomosis, which could be physiological, can form, and they are found to perform essentially the same function of physiological AVAs elsewhere in the body, like lung, episclera, etc., just maintaining their blood flow, thermoregulation, etc. And dysregulation of these physiological AVAs can contribute to the pathophysiology of pachychoroid. Now, it is speculated that apart from this, there could be a pathological variant, which is the acquired type, or better known as arteriovenous fistulas, can also form of sites of AV crossings, and AVFs also have been manifested to occur elsewhere in the body, and one common example is the dural AVFs, and these authors have found a lot of striking similarities between the AVFs in CSCR and dural AVFs, right from their clinical imaging features, and they say if it is a single AVA, it causes an acute presentation, where if it is a multiple or persistent AVFs, it causes a chronic presentation. But our challenge is to demonstrate this because of the limitation of the current multimodal imaging that is available. And finally, this is exacerbated by a thick sclera because that restricts the amount of fluid permeating through it. And also there is a longer intrascleral course of the vortex veins, which adds to the restriction of the outflow. And again, we have not been able to measure the posterior scleral thickness, but anterior scleral thickness have been found to be higher in CSCRIs, and this can be taken as a surrogate marker. And this raises a question of the role of full or partial thickness scleral window with or without ICGA guided vortex vein decompression as a treatment modality. So to summarize, this is the venous overload choroidopathy pathways as proposed by Spade et al. And we can see that there is either due to intrinsic or extrinsic effects, there is venous overloading, which leads on to remodeling and intervortex vein anastomosis. And if this initially starts as a compensatory mechanism, but in the long run, it is detrimental because it adds on to the choroidal venous congestion. And all this can occur without any clinical manifestations as seen in the yellow background. But if it continues for a long time, it eventually leads on to leakage through the RPE with subretinal fluid accumulation. And there it becomes clinically manifest, as you can see in the red background. And finally, if the fluid is able to exit through the sclera, then it is decompensated. It's compensated and the choroidal is decompressed. And this is shown in the green background. So to summarize, understanding of the pathogenesis still remains incomplete. Advances in multimodal imaging have definitely improved our understanding, and the latest theory focuses on venous overload of choroidal circulation. And this also highlights the role of the newer modalities like ultra-wide field ICGA in the evaluation of these eyes whenever it is available. Systemic conditions, mineralocorticoids, and genetics also have a role. But beyond all this, there could be some primitive abnormality which is mandatory to complete the CSCR phenotype, because as we know, typical CSR can still exist without pachychoroid. So better understanding of these mechanisms should lead to design and evaluation of novel therapies which can improve the visual outcome. Thank you.
Thank you, Lekha, for that very exhaustive and very concise presentation. I think the topic is open for comments and discussion for couple of 2 to 3 minutes. Any questions from the audience?
Yes, sir. Sorry? Yeah, even like it sort of acts mainly as the mineralocorticoid pathway hypothesis itself. So there are reports showing that, but I really don't. I think higher levels, sir.
There is no male predilection. There is no male predilection for CSR. No, I'm just saying testosterone. Do we have evidence for testosterone?
There are reports which says all these hormones may be elevated in these patients.
So just to add to that, testosterone backbone is the same as the steroid backbone.
Yeah.
So it is known to be associated, and people who take these hormones for lack of testosterone, some of them do present with CSCR. So there may be some correlation there.
Yeah.
Yes, sir. See, not one mechanism can really
No, I
explain
think
CSCR.
basically we still do not know. See, there are two aspects as far as CSCR is concerned. One are the structural abnormalities which have been described, like venous overload choroidopathy. There are different phenotypes of central serous chorioretinopathy. As we go through the course, that's the main emphasis on which I'll be talking about. And probably these are situations where there are different grades of venous overload choroidopathy that we are seeing in each type of patient. So we really do not know what are the other aspects. I mean, if you see the literature on CSCR, there are so many factors which they have said are risk factors for central serous chorioretinopathy, but still we really do not have very concrete evidence to say that, one particular thing is really responsible for the disease. I mean,
Okay. That I think I can explain with the latest theory where they say it is due to some AV anastomosis, and if it is a single anastomosis, it occludes on its own, and the CSR resolves. If there are multiple anastomosis or if they are persistent anastomosis, it can lead to chronicity. There are several theories, like with just one mechanism, you cannot explain everything. And again, related to the first question, it's not that in everybody CSCR is predisposed by steroids. There are many individuals, uveitis patients, we give steroids for longer term, high dose of steroids, they never develop. And some, and for steroids, it's just the usage, it's just not even the dose or the duration that matters. So still we have not fully understood what, and it's a multifactorial thing. Lifestyle modifications more than dietary. Lifestyle modifications are important, CSCR. Type A personality, control of stress, adequate sleep, all these are important. But dietary per se, I'm not sure. Maybe again related to steroid use for some allergy.
So I had a patient recently who had CNVM in one eye treated with Paginex, and he went out and took some medicines from Baba Ramdev and developed CSR in the other eye. And has been having anti-VEGFs for last 13 years, earlier based in US, now come to India. I treated him with micropulse in this eye. He has subsided. He has stopped the inciting agent, that is the Baba Ramdev medicine, I don't know. So those could be involved.
Can I have one question? One. So I just wanted to know what is the current thinking on the influence of topical steroids on the development of CSCR. And we are always talking about systemic and steroids in every other form, but not really of topical steroids and its association with CSCR. So I would like to know your comments on that.
Topical steroids are the least likely to cause. Yes.
So is there any particular reason?
I am not too sure.
There is actually I had a patient who had previous CSCR who underwent cataract surgery, and 1 month on steroids, within 3-4 weeks patient developed the fibrin CSCR, and it took a long time for resolving. I had a patient like that, but topical as such is unlikely to.
It is not mentioned as an association. So
it's just a comment on the diet and what you said about the medication taken. I also have a fair number of patients who are on some kind of supplements or something that is not very well known over the counter kind of medications, and they started, it could be topical, it could be hair product, cosmetic supplements, and true enough they actually develop CSCR, and when you tell them to stop it, so the
no, we do not know. Ranjana, I don't think
away,
that we can say that, see, this is like any disease, it's like that. We always equate it to something. Correct. And unfortunately, these are diseases which have got what do you call remission, exacerbation.
Yes.
So we really do not know what exactly caused the
remission. It becomes
so
difficult to tell whether the drug has caused it or the natural remission of the disease, unless we do a control.
But as far as steroids are concerned, I think there is enough evidence to show that steroids
in Singapore,
in any form
we have ginseng, which also has kind of steroid properties. So that one is a definite known factor.
Thank you.
Thanks.
Yeah, we move on to the next talk. That's on multimodal imaging in central serous chorioretinopathy by Dr. Mahesh.
This one? Oh, that's it, sorry. Thank you. I will be speaking on the biomarkers, clinical and prognostic in multimodal imaging. So clinical means it is not only imaging.
No,
slide is not moving.
We can take 10 minutes.
Yeah. Okay. There are a lot of problems with CSCR. We don't know what is the ideal treatment. We don't know why it is severe in some people, and we don't know why it recurs in some. Still, we say it is self-limiting disease, and there is nothing to worry. So we need predictors for diagnosis, treatment, and outcome. So that is why there are new classifications by J. Chablani and et al., which mainly focuses on the biomarkers of central serous retinopathy. So these are important. Few clinical biomarkers, I will tell you. I can call it biomarker. It's a clinical finding, right? It's a clinical finding. Fibrin. Fibrin is one thing that we commonly see in many of the CSCR. It is vision will be very much affected, and the recovery time is very, very long. And sometimes it can be even mistaken for choroiditis without. So the catch point is basically there is no vitreous cells, and you can see the angiogram with point leak. Now the other few biomarkers, sometimes we see some inferior little fluid, exudative detachment, where we see some subretinal fibrin. These are subretinal fibrosis, you can see that, and with some perivascular precipitates. These are some of the things that we should think about when diagnosing a central serous chorioretinopathy. So in these cases, inferiorly fluid will be there. It should not be mistaken for rhabdovenous retinal detachment. Then there are angiographic markers. It is not markers, you can say. Ink blot and smokestack we see. Ink blot is commoner, and the smokestack leak usually have large serous macular detachment, while ink blot leakage can result in more metamorphopsia, less fluid. This is one thing that we usually see. Then there is chronic CSCR. Angiographically, there are a lot of findings. In fluorescent angiogram, we can see a lot of RP tract and staining of the RP. There are window defects corresponding to the loss of RP. And so these are all features of chronic CSCR. And these are, you can call it some biomarkers in angiogram. Now, fundus autofluorescence is one very useful investigation in CSCR. In fact, even in some cases where it is mistakenly said AMD or something, you can find out that this teardrop sign or peripapillary hyperautofluorescence patches, which tells you that this patient had a CSCR in the past. So this is there are two things. Fundus autofluorescence tells about the RP function. So when there is hypoautofluorescence like the central area, RP is not at all functioning, and the sick RP is seen as hyperautofluorescence at the edge. So if it is totally dark, it is dead RP. The visual outcome may not be very good. So choroidal biomarkers are there. Already Dr. Lega has spoken about few things, choroidal thickness and everything. Choroidal thickness can be increased in CSCR. That is why it is coming under pachychoroid spectrum. We have seen patients when there is resolution of the fluid, choroidal thickness has reduced, like the top and below left side. Resolution of the fluid, choroidal thickness has reduced. And when there is a worsening of CSCR, choroidal thickness is increasing. So definitely there is a relation between choroidal thickness and CSCR. Then there is something called choroidal vascularity index, more of research things. But this also has implications in the pathogenesis of CSCR. Then there are some masquerades, or you can say like this is a case of diabetic retinopathy, and with a lot of microaneurysms in the fundus photo and angiogram. But you can see a small leak. So when you see such a large serous detachment, it is unlikely to be a diabetic retinopathy. Actually, it is little eccentric, not under the fovea. We see serous macular detachment, small serous detachment in diabetic maculopathy. Here it is little eccentric, and it's a large SMD. So large SMD, if you see, always think about central serous chorioretinopathy and not DME, or there is an underlying CSCR like picture in a DME. So then there are RP OCT biomarkers regarding the RP integrity. You can see that RP is totally irregular with hyperreflective dots in that area, suggestive of even subretinal precipitates and all. So this RP integrity is one important thing that will tell you the prognosis of OCT, the treatment. And this is the top picture has RP atrophy. There is a total discontinuity, loss of RP in that area with ellipsoid loss. And there are cystoid degeneration. That is another biomarker that tells you that already it is a chronic one, and the outcome of your treatment, even if it becomes dry, it is not going to be good. We have few cases. I have this, the top ones are these are cases which I did PDT, that large serous detachment, and even serous PED is there on the right side picture. And following that PDT, the resolution and even formation of ellipsoid line can be seen post treatment. Here the RP is totally not lost. So we can see these sort of conditions where there is a good prognosis. Here are few bad cases. Initially, the top pictures, you can see that the RP is totally irregular, and there is loss of ellipsoid and RP in almost all the sections. In these cases, after PDT, even though there is an early resolution in the second line, it recurs after some time, and the right side lower picture is the bad outcome of a chronic CSCR, that is intraretinal schisis with gross thickening. They are not going to do well. So this is a case where we have done PDT, and post-treatment you can see that that even the ellipsoid zone regenerates to some extent after some time. So these are better prognostic findings, and the other ones are bad prognostic findings. So this is another case, serous PED. Serous PED is seen in many cases of CSCR, and sometimes you can see that after treatment it collapses. Serous PED, we don't treat if there is only serous PED, but if you treat it, it may collapse after some time, and this is not a bad prognostic sign like a fibrosclar PED or notched PED or double layer sign, which is seen in some pachychoroid diseases. So this is the worst scenario. Bad Cscr, we call it Cscr. Clinically also, lot of pigmentation, hard oxidate, staining, RP tract, peripapillary RP changes, and bad cases like the left eye, you can see that there is no RP at all. These all hypo autofluorescent. So these cases are not going to do well. So this is even after photodynamic therapy, nothing is happening, and these are very delayed cases which are not suitable for any treatment, which are still an enigma in our practice. Cystoid macular edema I have already told, and there is something called cystoid macular degeneration and posterior cystoid retinal degeneration, which are bad prognostic biomarkers in OCT. And these cases will not leak unlike a CSCR, the CME in other cases, there will not be any pooling of dye also. It will not leak also. Double layer sign is one thing that you have to see in many cases of CSCR, because it is going to be a precursor for the next step in pachychoroid, that is CSCR, then pachychoroid neovasculopathy and polyp. So this is a spectrum of disease. So if you see double layer sign and some notches, it is going to give problem in your future. Some cases may develop later. So this is, then I have one or two slides on octa biomarkers, and you can see that this is looking like a fibrin CSCR. There was a leak, and it was treated with micropulse laser, I think, and but later you can see the double layer sign, hyperreflective double layer sign, and then fibrosclar PD, not good sign. In fact, after treatment also there was no improvement after micropulse. Then octa showed neovascularization, that is a network there. So it is going into the next stage, PCN, pachychoroid neovasculopathy, and it was treated with anti-VEGF. Then it responded and became flat. But fibrin will take months to resolve, and some improvement has to come. It will take months. So these are some octa biomarkers you can see, and which will be useful. So this is the spectrum, and definitely you have to look at the other end also, because some of your cases will land up in the PCN and PCV later. So always think about these biomarkers when you treat CSCR. So that is it. And clinical and multimodal imaging biomarkers are very useful in the management of so-called simple central serous chorioretinopathy, which is the most elusive retinal disease. Thanking you. Thank you. Any questions I can answer?
We'll have the discussion after the next 1-2 talks, because they are all interrelated. So the questions may overlap. So I'm just continuing from where Dr. Mahesh left. And my talk is basically to give you an overview based on our experience. And some of the cases that I show you are patients with very long follow-up of 10 to 12 years with central serous chorioretinopathy. So there is, as I told you, it's an enigmatic disease, because even today we really do not know how to classify central serous chorioretinopathy. We call it acute, chronic, recurrent. But unfortunately, many of the chronic cases may be recurrent cases, or many of the recurrent cases may be chronic cases, because when you have very minimal subretinal fluid, some of these patients are highly asymptomatic. And therefore, once you have one attack and then you come after about 6 months or 7 months, the patient may tell you, I was perfectly okay for the last 1 month. I'm feeling some distortion. But it's always possible that the first attack itself had not completely resolved, and now he has an exacerbation. And that's where careful follow-up with OCT becomes mandatory in patients with central serous chorioretinopathy. As Mahesh said, there are very important multimodal features in OCT itself to tell us that whether it's an acute disease or a chronic disease. So when you see hyperreflective dots within the serous macular detachment, or when you see cystoid changes within the serous macular detachment, you always know that this is not. Therefore, history is sometimes very not at all reliable in patients with central serous chorioretinopathy. Patient may come and tell us he is having a problem for 15 days. But when you do the OCT, you will know, and also the other multimodal imaging like fundus autofluorescence, we will know that this is not 15 days, but the disease has been there for quite some time. Therefore, biomarkers are very important for us to understand the prognosis and also the management of the disease. Therefore, as he said, autofluorescence, I feel, is very important. So when you get a patient with CSCR in your outpatient, I feel you should always do OCT and autofluorescence. Why? Because autofluorescence tells you whether he has had any attacks earlier. So patient may tell you this is the first attack, but you see patches of decreased autofluorescence in the macula, and that tells you no, he has had silent attacks earlier. It also tells you whether he's had an attack in the other eye. Therefore, autofluorescence with OCT is very important for us to evaluate central serous chorioretinopathy. Dr. Mahesh also showed this slide about the recent classification system which has been suggested by Chablani, my good friend. But then there are so many complex issues. But then what he has tried to do is try to classify CSCR based on the area of RP damage. That is, autofluorescence is used. So less than 2 disc diameters you classify as a better prognosis, and greater than 2 disc diameter you prognosis as a worse prognosis. But unfortunately, in RP changes, you may have patches of RP changes, and here again it becomes a very complex situation, and that's why this classification has really not really been accepted. But then I think Chablani and group are working on this to try and give a new classification system. Therefore, having said all this, we have got various phenotypes as far as central serous chorioretinopathy is concerned: atypical, bilateral, multifocal based on the fundus fluorescein angiography, inactive when you see some degrees of RP atrophy, but there is no fluid, but the patient is symptomatic. So I will just show you a few cases. So this is a young man who came with this is an acute CSCR. Why? Because the fluid is clear. There's nothing there. So when you see the autofluorescence, that also does not show much of changes. So this is really an acute CSCR where possibly this is the first attack, and this patient had a spontaneous resolution. But as you see, as Mahesh has shown, that resolution is coexistent with changes in the thickness of the choroid, meaning thereby the choroidal circulation itself has got a variation, and therefore this particular patient may later again come back with another attack. Therefore, he has had an attack, the fluid has gone, it may come again. But this is a case of a spontaneous resolution. We talked about many risk factors, like Dr. Ranjana spoke about diet, and we have seen that patients who are smoking, alcoholics, probably they are all a type A personality, where there is a system where the cortisone secretion in the human system itself on the higher level. So for some of these patients have recurrent attacks of central serous chorioretinopathy and changes in lifestyle like stopping smoking, alcohol, etc. I always advise patients with recurrent CSCR to make some lifestyle modifications, start doing some exercise, yoga, running, something like that, which may help, or stop some bad habits, or sleep. We have seen so many patients who come with CSCR who work only at night. They don't work at day, but they work, and therefore there's a change in the circadian rhythm. So that itself can act as a prism. So all these things probably have got an impact as far as the general system is concerned, the blood pressure, the heart rate, and therefore that also probably affects the choroidal circulation. So this is the next case where you see the fibrin, you see the vacuole sign. This is a case of multifocal central serous chorioretinopathy. And in our experience, we have seen that patients with multifocal CSCR usually need treatment. And usually we treat with focal laser initially, and you can see there's a complete resolution. So coming to management of chronic central serous chorioretinopathy, based on what I told you, we need to look at risk factors. We need to look at the age of the patient, and I'll come to that later. So extrafoveal we treat with focal laser. Unfortunately, low fluence PDT now is not available and very difficult. So we look into micropulse in some of these cases. And once you do not have a leak in fundus fluorescein angiogram and you see a persistent subretinal fluid, in some of these cases, Dr. Vignesh will be talking on oral medications, and he has done a lot of work on that. And if no response, again, go into micropulse laser or low fluence PDT. With this introduction, I just show you a couple of cases. This is a patient with 12 years follow-up with bilateral recurrent central serous chorioretinopathy, first seen in 2011 with reasonably good vision but a large serous macular detachment, who was managed initially conservatively, but the patient was coming back with recurrence off and on. And once they come with recurrence, we treat with focal laser, and they initially do well. But you can see here serial follow-up that although they respond to focal laser, they come back with the recurrence within a matter of 6 months, 1 year. So this lady, actually you can see here, as time goes by, the quantum of fluid is increasing, and you can see slowly the disease is getting chronic. Therefore, over a period of couple of years, she had couple of treatments with focal laser, and focal laser with mild treatment, and you, especially if you have yellow laser, is quite safe. It does not cause any significant damage, and therefore it can, and you can use only a 50 micron spot size and use as little burns as possible and do not cause any whitening of the retina. You just need to give a very mild treatment as far as central serous chorioretinopathy is concerned. Now, in spite of all this, the patient again was coming with recurrence, and finally she had bilateral photodynamic therapy. And after that photodynamic therapy done in 2015 till 2023, she has been asymptomatic. And with PDT, you can see here there is complete resolution of the subretinal fluid, and you can see at the 1.5 year follow-up, there is also a decrease in the thickness of the choroid. Following photodynamic therapy, the patient had reasonably good vision, 6/12 in one eye and 6/6 in the other eye. So this is the recent follow-up done in October 2022, and you can see the serial follow-up with autofluorescence, except for a patch of decreased autofluorescence way away from the fovea. Rest of the autofluorescence looks reasonably the same over a long period of follow-up. However, in a very recent follow-up, we saw that in the right eye, she has developed some sort of a LMH with a thin epiretinal membrane, but the left eye is absolutely normal. Therefore, this is a patient where after recurrent treatment with focal laser, finally with a PDT, we could arrest the disease for a long period of time. And our long experience with photodynamic therapy has been such that PDT definitely was very helpful in central serous retinopathy, and moreover, it prevents recurrences, especially in patients who come with recurrent disease at short intervals. So this is the next patient which I want to show you. This is a very interesting case. This is a doctor actually. He was initially diagnosed as central serous chorioretinopathy in the right eye, and there was no DLS. There were only some RPE changes, and this patient actually had an OCTA done initially itself because he was 60 plus years old, and therefore even the OCTA at that time, various segmentation did not show any subretinal fluid. So since it was a chronic Cscr type picture, the patient had a half fluence PDT. With that, for 2 years, he was asymptomatic with good visual acuity. However, 2 years later, he came back with a defective vision in the same eye, and at this period of time you can see the classic double layered sign and also the hyperreflectivity within the double layered sign. That's a very important finding to tell you this could be a neovascular membrane. Therefore, now he has got a definitive neovascular membrane there, and therefore, although clinically initially we could not find a neovascular membrane, after 2.5 years we could diagnose the neovascular membrane. So whether this is a Cscr which has slowly progressed to a pachychoroid neovasculopathy, or whether even with the available resolution of OCTA, we were not able to detect a small network initially, it's very difficult to say, but the importance of serial evaluation and the role of OCTA, especially in patients with slightly elderly Cscr, is being highlighted, and that again will be highlighted by one of the speakers earlier. Subfoveal leaks are really a challenge because these patients have chronic disease. They have chronic disease when they have subfoveal leak, and earlier we used to treat them with photodynamic therapy. Therefore, these were some of our indications for PDT in our practice for a long period of time. As I told, as we have been discussing about the various phenotypes of central serous chorioretinopathy, unfortunately, we see these sort of cases which neither respond to treatment, they have chronic disease, they have significant RPE changes, or what we call a diffuse retinal pigment epithelial atrophy. This patient has been under my treatment for many, many years with very poor vision in the left eye. The right eye still has got good vision, but still he has got mild serous mild fluid in the macula, and in spite of multiple years, never has he had a leak in fundus fluorescein angiography. He has been treated with micropulse, he has been treated with epleron, but continues to have some degree of fluid in the macula. So micropulse laser we do use in our center also. Dr. Ajay is going to talk on micropulse. I don't want to highlight too much, but then I feel, some of these cases do respond to micropulse, like this particular lady who responded to micropulse and did not respond to other forms of treatment. Therefore, as far as oral medications are concerned, possibly there is a role in some of these chronic cases who do not respond to other forms of treatment, but Dr. Vignesh uses it in many cases, and let us hear from him. It's very important for us to understand the role of OCTA, and in any patient with central serous retinopathy coming above the age of 50 years, and also patients coming with frequent recurrent disease, I feel today OCTA is necessary, especially you have it in your practice. So the take-home messages: number one, the importance of multimodal imaging. Detailed history is very important, especially if they are on any drugs that can cause the disease. Lifestyle modification, change of habits is very important. And OCT and FAF as a tool for follow-up, and chronic disease in elderly patients should be approached differently. Thank you.
Shall we have questions? A couple of questions we can answer, and then we'll go to the next talk by Dr. Jyoti regarding clinical findings, biomarkers, and all these things. One diagnostic test that is useful. Actually, clinical examination can diagnose CSCR because diagnosis is not a problem in CSCR.
OCT is the diagnostic.
But currently, OCT.
No.
Fluorescein angiogram we don't do initially itself, no. In only non-resolving cases we are doing fluorescein. So OCT is the test that we do every time.
Most important test is OCT.
Giri, I have a question for you. You said one case which had no fluid and was treated with PDT. No. The patient who had chronic CSR and they were not able to. So what I gathered was there's no fluid at all.
No. When there is fluid, we don't treat patients without fluid at all. Okay. Chronic recurrent disease where there is, periodic episodes of subretinal fluid, and that particular patient where elderly 62-year-old doctor, which I told you, fluorescein angiography did not show any leak. You understand? And there was fluid off and on coming in with metamorphopsia and scotoma, and therefore I treated with low fluence PDT at that time. Yeah. Unfortunately, at that time, OCTA also could not detect a network, and there even the OCT did not show any DLS, anything suggestive of a neovascular membrane. So I just try to show that, because we personally feel that any patient coming with fluid for the first time above the age of 55, 60, most probably they are all cases of type 1 CNVM, and basically, and probably at some point of time it becomes very obvious, and initially it may look like a central serous chorioretinopathy, and these patients need very regular follow-up.
Would you do, in such cases, would you do an ICG?
Yeah, we do ICG also, but I think OCTA is more sensitive than ICG to detect a neovascular network. And today, I think if you're doing ICG for CSCR, you must do wide-angle ICG. There's no use doing a macula ICG. You must do a wide-angle ICG, because if you want to really study if there is any vortex vein abnormalities, any dilated vortex vein, nowadays, as we are seeing, after we started wide-angle ICG, we are seeing that, one particular vortex is large, the other vortexes are small, meaning thereby there is an alteration in the circulation, and that may be one of the precipitating factors for central serous chorioretinopathy.
And CSCR in elderly, we don't wait like we wait in a young patient. 40-year-old first episode, we wait for some time. CSCR in elderly, we have to start little early.
Any other question? Okay.
Thank you, sir, and AIOS for this opportunity. With the last comment by Dr. Mahesh, sir, it makes my talk very easy. He said in CSR, in elderly, we need to treat early. I'll just skip the initial part because it's already been covered by the previous speakers. Mainly, I'll be focusing on octa changes in CSCR, and I'll be then shifting over to cases, two interesting cases, one of which has partly been discussed by Giridhar sir. The octa changes which have been discussed in CSCR, they have been described as hypoperfusion, flow voids, and detection of the ambiguous macular neovascularization in cases where you have SIR or the DLS. So the first case, I'll directly jump into that case. It's a 68-year-old gentleman who presented with scotoma in the left eye for a duration of few months. And since he was working abroad, he was unable to come up for regular follow-ups. But since he was there, that time we just did an OCT on this, which shows a serous macular detachment and an irregular RPE. And mind you, just note here that it is 2014. This is prior to the era when octa was in use in the clinical practice, or even it has not even seen the light of the day. So that time we observed, and to the patient's benefit, 2 months down the line, the patient's vision improved. OCT also showed a good resolution of serous macular detachment. And the patient kept on coming back for follow-ups as and when required. But then this time, again, there was a fluctuation of the scotoma pattern with a drop in the vision. Patient was advised investigations further, but the patient wanted to have go at observation, which was good for the patient. Again, 2 months down the line, the patient again improved spontaneously. Then somehow the patient was lost to follow-up for a period of 4 years, and after which he only underwent cataract surgeries in both the eyes. And mind you, from 2014 till 2019, the patient has never undergone any treatment for CSCR as such. Then COVID hit in, the patient was lost again to follow up, and only presented in April of 2022 with defect in vision in the left eye. So at that time, when we did the OCT, you can see 3 different sections from the part of the lesion. In the upper part, you can see a serous macular detachment, hyperfluorescent dots. You can see hyperreflective dots. You can see a peaked PED, intraretinal fluid, and a serous macular detachment. The patient also underwent ICG, and it showed up a very beautiful subfoveal polyp. So the patient was given a chance of brolucizumab, 1 dose, and following the injection, this is what happened to the lesion. The DLS almost flattened, the PED reduced in size significantly, and the serous PED completely collapsed. The patient also underwent an ICG following the injection, and following the injection, you can see with 1 injection itself, the polyp had totally disappeared. The patient was, due to the waxing waning nature of the disease and inability of patient to come for a follow-up, one more injection of brolucizumab was given, and the patient at his 3-month follow-up following the second injection had shown a significant improvement in all of the lesions which have been described. In this patient, over a period of 7 years, you can see the progression of the disease in an autofluorescence from the initial left upper part of the screen, almost a minimal area of hyperautofluorescence below the area of the fovea, to an increased area of hyperautofluorescence which is seen in the perifoveal location in the last follow-up an year back. Although this patient also underwent octa, but this octa was quite late in the course of the disease because it was not available prior to it. And at this point of time, it was before the injection. This is after the second injection, and this is following the second injection at the third follow-up, where there was a slight reduction in the network. Now coming to the second case, which was also highlighted by Dr. Giridhar sir, this is the same patient. It is a doctor, elderly doctor, and I've just put in the slide just for you to appreciate the fact that the patient's vision has never fluctuated beyond a certain limit. It's always been in the range of 6/9, N8, N6, that range. The patient only came with the presence of scotoma. That is the only complaint which the patient had. The initial presentation, there was a slight dip in vision that was around 6:15 N12. You can see a serous detachment temporal to the fovea. Left eye shows an ERM with a vascular distortion in the low inferior arcade. When we did the OCT, at that point of time, there was only serous macular detachment with an irregular RPE, some hyperreflective dots in the outer retinal layers. And we observed the patient, and the patient was told about the need for FFA in the second visit. The fluid automatically reduced in the next visit. FFA did only show just a mild window defect in the later phases of the angiogram. Since there was no leak, the patient was only observed. The patient again came in with a scotoma. We asked him again to undergo ICG and OCT because this was recurring. And since he was beyond the certain, the age for the typical CSR, so that time the patient again refused. He wanted to wait for it. But then the symptoms did not abate. The patient had to come back to us 2-3 months down the line when he underwent ICG. When we did the ICG, there was no polyp in the earlier phases of the angiogram. However, the later phases only showed something like a staining in the later phase in the inferotemporal part of the fovea. Left eye was normal. And this is how the OCT looked. Now, from a serous macular detachment, it has come to something like what is known as SHREM and an irregular RP along with it. The OCTA also did not reveal any pattern of frank network-like lesion, but still, due to the waxing waning nature of the disease and keeping in mind the patient's age, the patient was given a dose of, he was treated with a half-dose PDT, and this is the pre-PDT OCT, and this is how the patient looked 1 month following the PDT. On recent follow-up, on a follow-up 6 months down the line, the patient maintained a dry fovea, and he was asked to follow up every 3 to 4 monthly, but then he only presented after COVID abated, and he came in with a mild scotoma again. Now, at every point in time, his vision remains in more or less the same way. So at this time, we took the patient up for an OCTA. He has a frank DLS sign here with a serous macular detachment. And here the OCTA shows, I've not put in that other scan, but in the areas of just below the DLS, we could see flow signals which correspond to 2 areas of the network which are seen in the lower part of the slide. So the patient was given an anti-VEGF. Following the anti-VEGF, the fluid on OCT has gone, but the network keeps on changing its pattern and it is still persistent. So the network persisted, and so did we with the treatment part of it, and we kept on injecting till the network significantly went away. The patient actually landed up having somewhere around 8 to 10 injections, and in due course of time, the morphology of the network on OCTA also changed something into like a Medusa head appearance, as you see here. So this is in nutshell the case as seen on an OCT. In none of the follow-ups you see anything more than a serous macular detachment, irregular RPE, or probably a DLS evolving. However, the OCTA does show you different stages of a network which is responding to treatment, modifying, and then finally settling at a certain level. So with this, I'll just like to end my talk that CSCR in the elderly population tends to pose a significant challenge towards diagnosis and management. Multimodal imaging is crucial to diagnosis. OCTA definitely plays a significant role, and close observation with a high index of suspicion is often needed to manage a case appropriately. Thank you.
Any questions? We can have some questions. Any comments? I think there are some people, persons who would like. Any comments? Any questions? Yeah.
Thank you, Dr. Giri. I just wanted to know the brolucizumab that you used in your case. It shows that the ellipsoid zone gets disrupted, something that we had also seen in some patients in AMD. So, is it something that you're seeing commonly? And my second question or comment is
brolucizumab in particular, or in this case?
In that case that you showed.
In this case, it didn't affect
It
much.
didn't affect
The
the
vision
vision.
improved actually, and the patient stabilized following the injection.
Okay, and how closely do you follow these octa-related CNVs when there's no leakage to treat them?
Without, if they are asymptomatic, they can be followed up about 3 to 4 monthly.
So what I meant is that if you have no leakage on OCT, but you have these networks that are shown on Okta,
Yes, ma'am.
would you still treat them?
Ma'am, it
Because-
is based as per the general consensus. If the patient is asymptomatic, whether the network is present or not, we don't treat it.
But if the patient is symptomatic,
If the patient is
but there
symptomatic,
no
we may want to
fluid,
treat it.
No, we don't treat when there is no,
No
fluid.
fluid.
no
there's no
fluid, we cannot
We
treat,
don't-
but
we don't treat.
symptomatically we should.
See, the Okta is used basically to decide. We are using Okta in follow-up to decide the duration of follow-up. That is, if, depending on the changes in the Okta, if there are only these large vessels, that is, that are present, then we can tell the patient you come after 3 months. The possibility of early recurrence is not there. But then when you find these smaller networks but no fluid, you know that possibly in the next 1-2 months he is likely to have a recurrence. So we call them a little early. So you use Okta from that point of view. But just because Okta is showing changes and fluid is not there, we are not treating at this moment of time.
Thank you.
And regarding the brolucizumab, it's a very interesting observation that you're telling. I think we'll have to look into our cases as to whether it causes. One thing what we have noticed is, in our experience, PED height definitely reduces significantly in patients with brolucizumab when compared to other
Yeah, they're absolutely right.
anti-VEGFs.
The reason why I asked the question was also because of their study where they showed that the PED collapses. Despite that, the vision did not improve in their set of patients for the AMD.
But that may be related to the PED also.
Yeah,
the PED collapse.
Correct.
But in CSCR, usually we do not have that sort of a
PEDs.
collapse of the PED and
That's
changes.
right.
Yeah.
Thank you.
Actually,
Probably this big PED is what you are saying, ma'am. They might be having a degenerative or ischemic RPE at the top of PED, which is not letting vision improve even after they collapse.
So we move on to a very important topic, that is micropulse laser in central serous chorioretinopathy, and I think Ajay has done quite a lot of work on micropulse. So I thought it would be nice if he can share his experience.
Mahesh, for this opportunity to be part of this important course of the masterclass, and I'm talking on central serous retinopathy, when, how, and limitations of the micropulse laser. So there are no financial disclosures, and I think all these points which I wanted to relate have been taken care of. I just stress that we must ask the patient to stop all medications, including the homeopathic medication and health supplements, if we do not know much about them and they may be causing CSR. So my protocol for treating any patient with a micropulse laser is that I do not treat an acute CSR. I wait for 6 to 8 weeks. I would definitely ask them to reduce stress, have adequate sleep, stop smoking, use antioxidants. And as others have pointed out earlier, fundus autofluorescence is an important diagnostic tool with OCT, Okta. And initially, when a patient comes to me, I do an angiogram and an ICG as well. Now, subthreshold micropulse laser is generally not done for acute CSR unless and until patient insists that they cannot wait, and or if there's a chronic CSR, then we treat. So these are the patients which this was a much earlier study a few years back where all patients responded. There were 2 patients who did not wish to wait, were treated with micropulse laser, and you can see that within about 10 days, patient responded to a single treatment of micropulse and another patient responded in 2 weeks. Now, what is micropulse? Now, this is a seminal work which was done by Doran et al. And way back he showed that if we reduce the duration of a laser pulsation to as small a level, we will be localizing the damage caused to the retinal tissue up to the level of 1 microsecond. Will be causing damage to the retinal pigment epithelium. So the burn duration is equivalent to retinal damage. Now here you have a continuous wave laser, and if this laser is split into an on time and an off time, the off time basically indicating relaxation of the tissues, then that becomes a micropulse laser. So a continuous wave laser where you reduce the power to a particular level is not micropulse. It is a micropulse when there is an on time and an off time, so that means there is a duty cycle. For example, if I take a period of 2 milliseconds and the on time is 0.1 milliseconds, the off time is 1.9 milliseconds, it becomes a 5% duty cycle. If this becomes 0.2, it becomes a 10% duty cycle. If it becomes 3.3, it becomes a 15% duty cycle. So when I treat a patient with a continuous wave laser by reducing the power, I will not be producing a damage detectable on a color photograph, but it will be detectable on a OCT. If there's no damage on the OCT as well as color photograph, that is what happens in micropulse, where there's 100% tissue sparing. And we generally use a yellow micropulse laser, though people have used 532 at 810. The question which people ask is micropulse working? So there was a very good work done in Japan where they did lab studies where they showed on your left is a continuous wave laser, and the mark in the center is the damage caused by the continuous wave laser. So if you look at this particular figure, the damaged retina is in the middle, but the area around it is the area which possibly is the one where people believe something is being produced which reduces the damage, and people believe this is by the heat shock protein 70. So in a micropulse mode, the entire area gets spared, and they showed this. Please look carefully. This is what the damage is, and this is what was shown as production of the heat shock proteins. Now, what power to use? So this was a rabbit study which was done, which showed that as we reduce the amount of power, the damage caused to the retina was reduced. And if you look at it, the probability of retinal damage at 30% exposure was the least. This basically means that if I do a test burn in the micropulse mode and reduce it by 50%, I can have a non-damaging laser to the retina, and that is what is being done now. So earlier we were treating with micropulse with no test burn. Then we were doing test burn in a continuous wave mode. But I have been treating this, and now I think with J. Chablani et al., all of us all over the world have agreed that if you wish to treat, you must treat with a test burn, which we always give in the nasal part of the retina, usually in the lower infranasal quadrant. And after having got the test burn, I reduce the power depending upon the amount of fluid either to 40 or 50%, and that is how it is done. I'll show you some cases. So this was a patient of chronic CSR, a 63 years old male with an angiogram, and this is how the OCT looked like, and this is post micropulse. Patient did well. This is an interesting dentist who had taken all sorts of treatment, including epineuron. He was on it for last 5 years. He would have recurrence. He will have occasional metamorphopsia. He came to us, and this is his right eye. We had a suspicion of pachychoroid neovasculopathy in his right eye, and his left eye had fluid. So we went ahead and did. So right eye we treated with Eylea. We did not treat the patient with a micropulse in the right eye. In the left eye, we treated the patient with the micropulse. So what happens immediately in the first week? Patient may come back to you with a slight increase in metamorphopsia. So we looked at the OCT. We found that initially the neurosensory detachment of the subretinal fluid would increase, and subsequently it will flatten off. Now, for last 5 years, I have done 3 micropulse treatments for him, and he has remained stable, no epineuron at all. This was an ophthalmology resident, and when he started his residency, you can see that there is a pachychoroid, and he had in his left eye classical CSR. We treated him with micropulse. He has finished his residency now, and he has had 4 treatments of micropulse laser over the period of last 3 years, and he has responded extremely well. Now, what are the limitations? Now, the best micropulse works when the central foveal thickness is between 500 to 600. Earlier, I did not used to treat them if it was more than 450, but we have treated patients above that, and they do work. As I said, I always do a test burn. Usually the test burn is done with a 10% duty cycle is about 1200 to 1300 milliwatts. But please remember, your laser is getting old. So there's nothing like a standard test burn, because the RPE changes in an individual case will be different. So every patient we have to customize the test burn. I always clean the tip of my laser before I do a test burn, because I've had times when actually I was getting a power of 2000 milliwatts in the micropulse mode and yet not getting a test burn. You clean the tip and the laser and it works. In case it does not, which I've had an occasion where it did not work, then I increase the duration from 200 to about 240 milliseconds. Again, do it about 5% duty cycle and it works again. I avoid the areas that have been lasered or areas of retinal atrophy as demonstrated by fundus autofluorescence. And as I said earlier, the neurosensory detachment increases in the first 3 to 7 days and then it comes down. I do not repeat the micropulse. It's been shown in a Korean study that actually you can repeat it on a monthly basis, just like anti-VEGFs, but I do not repeat it for 6 to 8 weeks. And in a chronic CSR, you must rule out a pachychoroid neovasculopathy. So my take-home message is acute CSR observe, stop all steroids, reduce stress, treat other complicating factors like smoking and hypertension. Chronic CSR micropulse laser therapy, especially for the central leak, I go transfoveal. We have treated over more than 20 eyes now, where we have a success in 19 of them, which is, I think, remarkable. Since we don't have PDT available in the country, it can be repeated after 2 to 3 months. It is safe, does not cause damage to the neurosensory retina. It is definitely cheaper than PDT. There is no dye injection. Octa helps us in detecting the pachychoroid neovasculopathy, which can be treated with ILIA, and subsequently we have treated these patients with a micropulse when we were sure that the PNV has subsided and there's a fluid component which was related to CSR. Thank you. And Dr. Giri told me to stop it at 8 minutes. I'm doing that.
You, Ajay. Unfortunately, I don't think there is time for discussion because we are running out of time, and we will be. Any questions? One question we can take as Vignesh puts a slide.
So normally we do it with a 200 size, 200 milliwatts. I've changed from 5 to 10% duty cycle. Take it to 40% of my test burn. If it is good, yeah, the spot size is 200 SN. So then, and we cover. I go transfoveal. I cover the entire areas. Supposing there's a leak is subfoveal, then maybe I am a little careful in those cases ongoing. So you can, I take either 5x5 or 7x7 because you do a multimodal, this multi-spot this thing. So I start from the nasal side, come down vertically, go temporally, come down vertically, then I treat my superior part, treat my inferior part, and then if I'm sure I go transfoveally and I have done it repeatedly, it's not causing any damage.
It's a grid. It's a grid.
It's a grid.
If it's a large area, you can even use 500, but you have to do the test burn with 500. Right.
No, I do a test burn with 200 and I treat with 200.
No, if there's a large area,
increase the size.
It's a large area, you have to cover the whole area with a grid. Then probably some of the chronic changes.
So the grid can be 5x5 or 7x7 or 6x6. So
Agreed.
I do a 5x5 or 7x7. So it comes
next you
yes,
okay.
Yes.
The other, even the other one is an accident.
Yeah.
The spacing between the spots? No gap.
No gap. Zero.
And you do it multiple times for each area or just once? Once.
So as Dr. Lutful said it, he says you could go all round and you could go even obliquely, and you can treat the same area, but I prefer to treat it once. We have a particular way of treating it. It's all mapped out that I'll start it at this area, go in this particular manner, so that I don't have to repeat that treatment area again.
Thank you.
I think once you are given one cycle of treatment, you can wait for 3 months, at least 3 months,
Yeah,
isn't
3
it?
months.
And after 3 months, if you find that the fluid is significantly reduced, you can hold on. But if there's no change, I think you can do
So
a
I
repeat
call
treatment.
the patients back at 3 weeks, then at 6 weeks. 3 weeks because I want to see them that everything is going on well. Usually the fluid is down by 3 weeks. If you do an OCT, then we to do a serial measurements, show it to the patient, and patient seems happy. I think that happiness index helps them to improve further.
We've come to the, last talk. We are just cutting short with Vignesh. Vignesh, yeah.
Yes.
We started 10 minutes late, so I think the organizers have given us 10 minutes extra time.
So good morning. I thank Giridhar sir for this opportunity. CSCR management, like many times, the treatment of chronic CSCR is challenging despite many therapeutic agents or laser procedures. Is there a role of eplerenone or spironolactone in the treatment of CSCR? So let us see on that. So the involvement of the mineralocorticoid receptor pathway in the pathogens of CSCR was identified in animal model. Intravitreal injection of aldosterone resulted in choroidal thickening. And to prove their point, the researchers here treated 2 patients of persistent CSCR with eplerenone for 5 weeks, and there was a complete resolution in 5 weeks, and it persisted for another 5 months. The first pilot study again studied on eplerenone in CSCR, which resulted in significant reduction in central macular thickness, SRF level, and improvement in visual acuity. And then there was another study on spironolactone, where patients were treated with spironolactone 25 mg twice daily, 12 weeks, had a very good reduction in SRF as well as improvement in vision. And another study compared spironolactone with eplerenone. Spironolactone was superior to eplerenone in terms of BCVA improvement. However, both drugs were equally effective in reduction of subretinal fluid. The first randomized double-blind placebo-controlled trial showed that the treatment group with eplerenone had a significant improvement in visual acuity and SRF reduction. So they concluded that it's safe and potentially effective, the treatment of chronic CSCR with persistent SRF. Then again, another major review of literature on the treatment of eplerenone, treatment of CSCR with eplerenone concluded that oral eplerenone at a dose of 25 to 50 mg per day was effective and well tolerated for the treatment of chronic CSCR. Significant improvement in visual acuity and decrease or total absorption of SRF was noted in these studies, and patients presenting widespread RP changes were less likely to benefit. However, a major blow came to because of this study called the VC. So they concluded that eplerenone was not superior to placebo for BCVA improvement in people with chronic CSCR after 1 year of treatment, and even they recommended that not to use eplerenone for chronic CSCR. However, this study had some limitations, like these authors have discussed. Like they considered as a high baseline BCVA of 6.9. Functional outcome like BCVA was used instead of as a primary endpoint instead of the anatomical outcome. A rebound effect was not accounted. SRF thickness was measured instead of SRF volume. And these authors concluded that VC study to stop prescribing eplerenone for chronic CSCR is too severe. So eplerenone is a aldosterone antagonist type of potassium sparing diuretic. It's a selective aldosterone receptor antagonist. So unlike the spironolactone, which interacts with the hormonal receptors leading to hormonal side effects, eplerenone does not have that. Even though it is less potent than spironolactone, it is approved for use in the treatment of hypertension and heart failure. Hyperkalemia is a serious adverse effect, but it is not commonly seen. Other minor adverse effects include headache, drowsiness, dizziness, body ache, and tiredness. So before starting eplerenone therapy, it is advisable to have a baseline renal function test, liver function test, and most importantly, serum potassium. Eplerenone is started only if the above parameters are within normal limits and there are no systemic contraindications. So I always advise efficient fitness to be taken before prescribing eplerenone. Serum potassium to be monitored in the first week and every month follow-up. Eplerenone in a dose of 25 mg once daily is started for a week, and there are no adverse effects reported by the patient, or the serum potassium remains within normal limits. Dosage is increased to 50 mg once daily and continued until there is resolution. So the OCT predictors of eplerenone therapy are thicker subfoveal choroidal thickness, smaller subretinal fluid maximum diameter, lower number of serous PEDs, and lower number of intraretinal hyperreflective foci are significant predictors of complete SRF resolution at 3 months with the treatment of eplerenone. So let us see like in the various like CSCR, like various classification of CSCR, like acute CSCR, there is a greater and faster resolution than observation, faster visual acuity improvement, and even like SFCT in the fellow eye was reduced. So in this case, we can see a 47-year-old male patient, defective vision of 1 month duration and vision of 6/9, but there is no leak on the FFA except for the PED seen in the along the superior arcade. But you can see here a complete resolution within 15 days of starting the treatment. So another case like where there was subretinal fibrin with a leak, this fibrin like just melts. Like we can see in 1 month time there is a very good reduction and almost near resolution of the SRF along with the fibrin. In chronic CSCR, significant improvement in BCV as compared to placebo, improvement in CMT and SRF levels in the eplerenone treatment, whereas it worsened in the placebo group. So in this like study like done by me and my colleagues, we compared micropulse laser with eplerenone. These were really chronic cases with widespread RPE changes. We observed in this study like micropulse laser to be superior to eplerenone. However, like we had like improvement of complete SRF resolution was seen in 42.8% in micropulse group and 20% in the eplerenone group. So compared to half dose PDT, the SPECTRA trial. So here like they have shown that half dose PDT is superior to eplerenone both in safety and outcome, both at the 3rd month as well as the 1-year follow-up. However, there was another study where in chronic CSCR refractory to PDT, eplerenone was beneficial. So in this case of a chronic CSCR, a 45-year-old male patient, defective vision of 4-month duration, we can see the leaks here. Very good resolution, very good decrease in 1 month and complete resolution by 2nd month with improvement of vision from 6/12 to 6/9. There's another case, this 52-year-old male patient had defective vision right eye of 6 months duration. We can see small PEDs. I ruled out neovascularization. And see here, like the no SRF in 12 days. The SRF was there for 6 months, more than 6 months, according to the patient for symptoms. But here it resulted in no SRF in just 12 days with the PED still persisting. So again, like CSCR with CMD. Here also, like we have tried eplerenone. There have been some reports of like good decrease. So in this case, we can see IRF with subretinal fluid. There was complete resolution and vision improved from 6/12 to 6/6. And that it persisted for at least another 6 months after stopping the therapy. In this case, again, there was like a decrease in both SRF and IRF with eplerenone. However, it looks like it doesn't act in every case, but this case here, a 48-year-old male patient, defective vision in right eye for 13 years. So the chronic CSCR of 13-year duration, we can see the cystoid macular degeneration. There was some decrease, but however, again, it came back along with the treatment. So in bullous CSCR also, it has been tried. So I'll just share my cases. Here, like a 30-year-old male patient, BCV of 3/60, defective vision of 2 months. It was treated as macular choroiditis elsewhere with oral steroids. But once the oral steroid was started, the patient himself stopped because it worsened. So he came to me with this stage. We can see here, this is I called a melting of subretinal fibrin. Whenever there is fibrin, my first choice will be eplerenone. Another case, here again the bullous CSCR, 45-year-old male patient, defective vision of 2 weeks duration. We can see multiple leaks as well as fibrin and the inferior bullous detachment in the B scan. So what I did was I treated with eplerenone. After 2 months, there was fluid. So what I did, I additionally added micropulse laser to hasten the recovery. So here we can see a complete recovery of bullous CSCR with both eplerenone and micropulse laser. Micropulse was done after decreasing the leaks with eplerenone and thereby achieving the complete resolution. We can see even the inferior bullous RD resolving in 3rd month and the macular fluid resolving at 4th month. So to conclude, eplerenone is beneficial in the treatment of all types of CSCR. There are no safety issues except for hyperkalemia, which is uncommon. But however, we have to screen the patient before starting, make sure that they are fit. Efficacy is lesser in long-standing cases of CSCR with features of chronicity. Eplerenone may not be effective in cases where the risk factors are not eliminated or reduced. Like if the patient is already on steroids, again, if you give eplerenone, it may not be effective. And in all cases of CSCR, it may not be effective because we have studies on the genotype, the genes involved in the mineralocorticoid pathway. Different haplotypes of the gene involved in the mineralocorticoid receptor may be associated with severity in CSCR cases. However, like we need prospective long-term RCTs comparing eplerenone with other modalities. Thank you.
Thank you, Vignesh, and we come to the end of this session. I don't think there is any time for discussion. I'm sorry, Vignesh. I'm sure there will be a lot of questions, but due to scarcity of time, we wind up. Thank you all speakers, and thank you, Ranjana, for having been part of this. We can have a small photograph together, and then we vacate the seats.
Please stay back, sir, for this session.